Good afternoon, and welcome to our final installment of our palliative care webinar series, Evidence-Based Approaches to Treating Symptoms in Patients with Kidney Disease. Today's webinar will be recorded and put on the RPA website for future viewing. Our presenter today is nephrologist Dr. Woody Moss, Director of the Center for Health Ethics and Law, Sections of Nephrology, Geriatrics, and Palliative Medicine at the West Virginia University Health Sciences Center. So we are very happy to have him. He has done the first two along with Dr. Dale Lupu. So we have just been having a great session so far. So we are looking forward to this last one. We encourage questions and participation. So please feel free to put your questions in the Q&A box and your comments in the chat. And Dr. Moss will address those during and or after the presentation. So I'll now turn it over to Dr. Moss. Dr. Moss?
Thank you, Desiree. Let's talk about evidence-based approaches to treating symptoms in patients with kidney disease. And my objectives, or the learning objectives for you, are that you'll be able to explain that symptom management is important to patients, describe 3 systematic approaches to assessing symptoms in dialysis patients, discuss how well nephrologists do in identifying patients' symptoms and treating them, address some of the most troublesome symptoms to patients: restless leg syndrome, pain, anxiety, depression, and itching. Propose strategies. You'll be able to propose strategies to improve symptom management. And then I'm going to point you to some online algorithms for treatment of common CKD and ESKD patient symptoms that you'll be able to use, or you'll be able to ask your nurse practitioner or physician assistant use to help manage your patients and improve their quality of life. This is the first polling question. True or false, patients prioritize outcomes relevant to their daily living and well-being, whereas nephrologists and researchers tend to prioritize mortality and biochemical parameters. True or false? Okay. This is a familiar group. That's absolutely right. I'm going to show you some data to support this. Next slide, next polling question. True or false, the higher the symptom burden patients report, the worse they rate their quality of life. And 95% that is true as well. And Sarah Davison has 1 or 2 studies. I co-authored a study with Paul Kimmel. Steve Weisbord, I think, has several studies. So there are multiple studies finding the same thing. There's an inverse relationship between the patient's symptom burden and the report of their quality of life. Now, there's a disconnect between what nephrologists and researchers have traditionally looked at with regard to research priorities and even treatment priorities, and what patients report is most important to them. So this was a study from Canada and Australia, really talking to 68 patients and 24 family members, and they identified 68 outcomes that could potentially be priorities for outcomes in hemodialysis. And of the 68 outcomes, I'm just showing the figure that had the top 33. And if you see to the left, you see a sort of orangish colored arrow. Those are symptoms that were important to patients. And notice that of the first 10, 4 are symptoms. And actually, you could argue that some of these others are symptoms too. But really, to patients, they prioritized symptoms that would improve their lifestyle, would improve their psychosocial outcomes. So things like fatigue, energy, resilience, ability to travel, being able to sleep, less anxiety, a better appetite. Those things are important, but things that researchers might look at, like mortality or survival. Notice that was only number 14. And then down here are things like restless leg syndrome, cramps, itching, nausea, and vomiting. So what they concluded was that researchers need to focus on outcomes that are important to patients, patient-relevant outcomes, and that would enable the care that clinicians provide to be more patient-centered. So in looking at this, they said that most important to patient were lifestyle and psychosocial outcomes, and that symptoms would become more important if they were severe and unrelenting and really intrusive to the patient's lifestyle. So this was a different way of weighting the importance of things that researchers might take account of, and really nephrologists as they're caring for patients. This is an important slide because it tells us that there's an inverse relationship between the symptom burden that patients experience and how they rate their quality of life. So if I can walk you through this, on the x-axis is the McGill Quality of Life Total Score, the McGill Quality of Life Physical Subscale, the McGill Quality of Life Single Item Index. It's a simple question. It's down here at the bottom, considering all aspects of my life: physical, emotional, social, spiritual, and financial. My quality of life in the last 2 days was very bad, which would be rated 0, or excellent, which would be rated 10. And this single quality of life item index correlated statistically with the total score, the physical subscale, and also the satisfaction with life scale. And what you see is the pink is no symptoms. So if the patient reports no troublesome symptoms, as opposed to the yellow, which is 1 symptom, and the blue, which is 2 or more symptoms, the fewer symptoms the patient reported, the higher they rated their quality of life and their satisfaction with life scale. And this was statistically significant. So the reason, really, one of the arguments for today's talk is that not only do patients say it's important, but really by attending to their symptoms, we can improve their quality of life. And then what are the symptoms that patients report that are most bothersome to them? So this is an English study. Fliss Murtaugh was the first author. These were patients with stage 5 chronic kidney disease. And Steve Weisbord at Pitt and his colleagues have shown that really the symptoms that patients have with stage 5 CKD and the symptoms that they have with end-stage kidney disease are the same, so that really we can go back and forth between dialysis patients and stage 5 CKD patients in looking at the data. So what were the ones that were the highest? Itching, lack of energy or fatigue, feeling sad, pain, and worrying. Those were the ones that were over 50% in this study. And then in another study, and this is Steve Weisbord from Pitt, and he developed what's called the Dialysis Symptom Index, which included 30 items. And in his research, he found that dialysis patients report on average a median of 9 symptoms. In this table, the symptom is in the far left column. The prevalence of the symptom reported by dialysis patients is in the middle column, and how severe on a 0 or on a 1, not at all bothersome, to 5, very much bothersome, is the scale. So 5 would be the worst severity. And notice the arrows again. So feeling tired or lack of energy is 69%. And notice only one other, dry skin, was higher than that in prevalence. And it had a mean severity of 3 over 3. Pain, whether it's bone or joint pain or chest pain, notice bone or joint pain was much higher in prevalence, but you can add all of these together if you're going to talk about pain overall. And notice the severity score was the highest of the scores. And then notice dry skin, although very prevalent, wasn't quite as severe, but itching was up over 3 and severe. So this gives us another patient population. And again, there's pretty good agreement on the symptoms that bother dialysis patients. Now, this is a study from the Netherlands looking at dialysis patients, and notice that their top 3 symptoms were fatigue, itching, and muscle cramps. And for these 3, there was no difference between the 120 hemodialysis patients and the 106 peritoneal dialysis patients in this study. But notice that easy bruising was much more common in hemodialysis patients, and lack of appetite was much more common in peritoneal dialysis patients. Now, how well do nephrologists do diagnosing and treating their patients' symptoms? And on the left is a study from Steve Weisbord and his colleagues at Pitt, renal provider recognition of symptoms in patients on maintenance hemodialysis.
And what he concluded is that renal providers are largely unaware of the presence and severity of symptoms in their patients. Implementation of a standardized symptom assessment process may improve provider recognition of symptoms and promote use of symptom alleviating treatments. And so the dialysis symptom index is one of the ones that would be a standardized symptom assessment process, the one that Steve and his team developed. And then notice there was an article 3 years later in the Journal of Pain and Symptom Management. Steve Weisbord was also a co-author on this, and it was done at the University of Virginia when where Renee Claxton was a resident who actually ended up going to Pitt as a palliative medicine physician, and Jean Holly, who's both a palliative medicine physician and a nephrologist, was at the University of Virginia at that time. And what did they find? They found that most patients had their symptoms untreated. So not only under treatment, but untreated. And if we look at this next slide, this is from their study. And what they found is that primary care physicians, more often than nephrologists, treated the patient's symptoms. And so again, these are pretty common to us, the symptoms that that we were talking about on previous slides in terms of muscle cramps, restless legs, bone or joint pain, sleeping. These are pretty common. And notice that, again, the primary care physicians more often treated, especially the anxiety and depression symptoms of these 62 patients in this study. So one other study, again, looking at how well do we as nephrologists identify and treat our patients' symptoms. And this was a study done at Rogosin Dialysis Centers in New York. And they identified 3 main barriers to symptom management. The first one, which is consistent with Steve Weisbord's studies, is that providers were unaware of patient symptoms. The second thing that maybe the Renee Claxton study alluded to is it was unclear for these patients whose responsibility it was to treat symptoms. Was it the primary care physicians? Was it the nephrologists? And without a clear delegation of responsibility, it could be, as you saw on the previous slide, that actually no one was treating the patient's symptoms. And that could lead to the findings that Renee Claxton found that really the patients had their symptoms untreated. And then the third thing they found was that nephrologists believed that some symptoms were basically untreatable. And here's a quote in the study. A nephrologist, you kind of feel helpless. I don't know what else I should be doing to make them feel better. I don't know what else I should be offering as a physician because they're so miserable. So really, we're going to address this because I'm going to point you to some algorithms that will help you know how to treat some of these common symptoms. And so hopefully you'll find that helpful. And the good news is then you'll be able to do what's most important to your patient, and you'll be able to help them improve their quality of life.
So another polling question, Steve, true or false? There are 3 relatively simple, straightforward, validated tools nephrology clinicians can use to systematically assess their patient's symptoms and their severity. I guess the question is, you're wondering, are there 2? Are there 3? Are there 4? And 89% of you knew that there are 3. That is correct. And so we've already talked about the dialysis symptom index, and we're going to be talking about the Edmonton Symptom Assessment Scale and the Integrated Palliative Outcome Scale.
On this next slide now, the Kidney Disease Improving Global Outcomes Controversies Conference on Kidney Supportive Care that was held in Mexico City in 2013 and then resulted in a number of articles. This one, the executive summary in Kidney International, and then a bunch of articles in the Clinical Journal of the American Society of Nephrology in 2016 in a moving points issue. This is what they had to say with regard to symptom assessment and management. First of all, they are critical components of quality care, really, for patients with advanced chronic kidney disease. And they endorsed, we've already talked about the dialysis symptom index. They endorsed tools. Notice that they didn't endorse the dialysis symptom index. It is 30 items. It tends to be a little bit bulky and time consuming. They recommended the Edmonton Symptom Assessment Scale Renal, which I will show you. and the integrated palliative outcome score renal, and I will show you that as well. And they recommended incorporating one of those into your routine practice. And then they suggested a stepwise approach. You might start with non-pharmacologic interventions and then go to pharmacologic interventions. So for example, dry skin is a very common cause of uremic pruritus. And so a non-pharmacologic intervention would be doing a much better job of moisturizing the skin with emollients, with maybe oil-based soaps that would tend to dry out the skin less, with perhaps washing less frequently, especially during the winter when dry skin is more common. And then they noticed in their evidence-based literature review that there was sufficient evidence to develop guidelines for uremic pruritus, sleep disturbances, restless leg syndrome, pain, and depression. So I promised you that I would show you the Edmonton Symptom Assessment Scale Renal. Notice that there are 11 items. At the bottom is the website where you can download this, print it off. And in fact, I would recommend that you give it to your patients, perhaps once a month while they're sitting in the waiting room, waiting to come in for a treatment. Perhaps if their family's with them, they can help them to complete it. Patients with lower health literacy might need a little help with this, but the goal would be not that you're trying to, every time you round, address, all 10 of their symptoms. You might ask them which one or two or three of these are the most troublesome to you, and maybe this month address the one that's most troublesome, next month pick up and address the next one, or maybe your nurse practitioner, if you have a nurse practitioner in your practice, could address some of these symptoms too, especially as you point your nurse practitioner or your physician assistant to these online algorithms for how to treat these symptoms. Now, the other systematic tool that you can use is the Integrated Palliative Outcome Score Renal. This one is used by, for example, and I'm going to talk about them a little bit more, and I actually talked about them last week too when we talked about active medical management without dialysis. The Nephrology Palliative Care Group at New South Wales, Australia, headed by Mark Brown, nephrologist Mark Brown, tends to like to use this one because it gets even a little bit more into the patient's mind with regard to what's really bothering them. Notice the first question: what have been your main problems or concerns over the past 3 days? And so this will really help you address what's important to your patients. And if you're addressing what's important to your patients, you're going to improve, first of all, their satisfaction of your care for them, and also you're going to improve their quality of life. Notice that this is very similar. There's a large overlap between the Edmonton Symptom Assessment Scale in terms of the symptoms and this IPOS renal, but instead of on a 10-point scale, it's not at all, slightly, moderately, severely, or overwhelmingly. So it's more of a 5-point scale, and pretty much similar, although I don't think diarrhea was, for example, on the ESAS renal. And then please list other symptoms not mentioned above. Again, this is one more way to tailor this to individual patient needs. And then the second page is over the past 3 days. This gets into how anxious have they been. What about the family? Have they been anxious? Have you been feeling depressed? It's interesting, there are some studies in the palliative medicine literature. The best way to tell if a patient is depressed is to ask them, are you depressed? And so this is somewhat of a variant of that, but has been found to be effective. Have you felt at peace is more of a sort of spiritual, existential type of question. Have you been able to share how you were feeling with your family or friends as much as you wanted? Do you have as much information as you want? Again, this goes from 0 always to 4 not at all. And then problems with any practical problems resulting from your illness. Have they been addressed? And then whether or not they've been addressed from 0, problems addressed, no problems, to problems not addressed, which is a 4. How much time do you feel has been wasted on your appointments? How did you complete this questionnaire on my own or help from staff? So notice this one is 2 pages, and I bring that up only because When I've been talking to colleagues, they say, well, what about the KDQOL36? You didn't mention that one. So the KDQOL36 was not recommended by KDIGO in their recommendations for symptom assessment and management. The Renal Physicians Association, in the second edition of their clinical practice guidelines, shared decision-making in the appropriate initiation of and withdrawal from dialysis, also recommended either the ESAS renal or the IPOS renal. Didn't recommend the KDQOL. I looked online, and there are several different versions of the KDQOL. One's 6 pages, one's 15 pages. I know you probably in your dialysis center have patients complete them twice a year. But as I've talked to nephrologists and others who work in dialysis centers, they tell me that they really haven't analyzed the results and followed them longitudinally and then tried to really intervene to change that. So I'm afraid KDQOL is too long, and it may not get into quite as many psychosocial existential issues as the IPOS renal. And certainly it's much longer than the ESAS renal. So if you really want to focus on symptoms, the ESAS renal that's just 1 page allows you to do that. If you maybe occasionally want to look at psychosocial and spiritual things as well, then you might want to use the IPOS renal, maybe twice a year, maybe every 6 months, and use the ESAS renal monthly in between. But this would be a way to really evaluate how your patients are doing in areas that are most concerned to them. Now, we talked about restless leg syndrome as one of those symptoms that patients report. Notice on the right-hand side are the diagnostic criteria from the International Restless Leg Syndrome Study Group. I bet you weren't aware that such a group existed. So it's an irresistible impulse to move one's legs, often accompanied by unpleasant sensations in the legs. And then this is a further description of them. These are usually more severe in the evening or at night. And the clinical criteria are not caused by any other medical or behavioral condition that could possibly mimic restless legs, like myalgia, venous stasis, leg cramps. And so then they suggest taking a detailed history to make sure you're really dealing with restless leg syndrome. Look at things like intradialytic aerobic exercise. And I know some dialysis centers have exercise bikes that patients could use for 30 minutes, let's say. It's been shown to actually improve patients' overall condition, may help them maintain their blood pressure during dialysis. And then here you're finding it may actually improve the restless leg syndrome. And then medications like Requip, the dopamine agonists, pramipexole, or low-dose gabapentin have been shown there's an evidence base to support their use. So this is what you could do for restless leg syndrome. And then we're going to talk about dosing of gabapentin, but it's not the way you would dose patients with normal kidney function. So what about treating pain? And we'll talk about gabapentin more here. What about treating pain? Notice in the left-hand column are recommended medications. So acetaminophen, what's in Tylenol is fine. This would say that hydromorphone is recommended, and I would put this caveat: as long as the patient is continuing on dialysis and the hydromorphone 3-glucuronide metabolite is being dialyzed off, hydromorphone's okay. But really the preferred drugs for severe pain for dialysis patients are fentanyl and methadone and buprenorphine, because none of those 3 have active renally excreted metabolites. And then the advantage of methadone is that there are some reports that methadone may help not only nociceptive pain, the aching, throbbing type of pain that's bone and joint and muscle type pain, but methadone may also help the neuropathic pain, the tingling, shooting, stabbing, numb, sort of burning pain that dialysis patients get, often with, for example, a diabetic peripheral neuropathy. So remember, methadone can sometimes get both nociceptive and neuropathic pain. And methadone, if you were going to start it, you would start at a very low dose, like 2.5 milligrams twice a day or 3 times a day. And if you're not comfortable with methadone, that's a drug that maybe a pain specialist or a palliative care consultant could help you with your patients. Now, neuropathic pain, unfortunately, is very common in dialysis patients, and gabapentin has been shown to be helpful. It's probably the first go-to drug. But the problem is it can cause drowsiness, it can cause leukopenia, it can cause what patients say, my brain just feels fuzzy. And so what you might want to start is 100 milligrams at bedtime on the days of dialysis. So really pretty much every other day. And you could titrate up every week or so, go from 100 milligrams at night to 200 milligrams at night to maybe a max of 300 milligrams at night. I've seen some people go up to 600 milligrams in dialysis patients, but really that's above the usual recommendation. Usually 300 is the max in dialysis patients. And then if it's available to you, pregabalin, the brand name is Lyrica, which can be much more expensive, but sometimes is effective when gabapentin isn't. Doses up to 100 milligrams are generally considered safe in kidney disease, especially for dialysis patients. Now, the medications in the middle column used with caution are tramadol, and notice that the dose is limited in dialysis patients to just 100 milligrams a day, whereas for people with normal kidney function, the upper limit would be 200 milligrams a day. Hydrocodone and oxycodone, the use with caution is because there are just a few more anecdotal reports of patients having reactions to hydrocodone and oxycodone. In my experience, and looking at me, you can tell that I've had lots of experience taking care of patients with kidney disease. I finished my fellowship in 1980. So lots of experience taking care of patients with kidney disease. And honestly, I've never had a problem using hydrocodone or oxycodone to treat pain. Whereas I have had problems with hydromorphone in dialysis patients, especially getting opioid neurotoxicity, which mimics uremic toxicity. They can get somnolence, they can get myoclonus, multifocal myoclonus, they can even get asterixis. And if you really didn't pay attention, it can progress to seizures. So, but I've not seen any of that with hydrocodone or oxycodone. In fact, I even did a study using oxycodone to treat pain in dialysis patients and saw no adverse effects and saw excellent results in terms of treating nociceptive pain. And then if you're treating neuropathic pain and the gabapentinoids, if gabapentin and pregabalin have not worked, then others that are recommended are disipramine and nortriptyline. You would probably start at 10 milligrams at bedtime, and you can titrate up slowly, perhaps increasing the dose every week or two to a maximum of typically 150 milligrams. But honestly, I've never really needed to go above 75 or 100 milligrams to really have patients report to me that they've had a significant improvement in their neuropathic pain. Now, the drugs not to use are morphine, codeine, meperidine. That's the generic name for Demerol. Some of us may be old enough to remember Demerol, and propoxyphene, which is what used to be in Darvon or Darvocet in 100. Probably some of the older nephrologists listening to this may remember those, but those are not recommended to be used because of renally excreted active metabolites that can cause opioid neurotoxicity. Now, people will always ask me, because a lot of people are used to using morphine to treat severe pain, at what point do you cut off and just stop using morphine in your patients with kidney disease? Well, I can tell you that I definitely don't use morphine in stage 4 and stage 5 chronic kidney disease patients. If I have patients potentially who are going to be only on morphine short term and they maybe have stage 3A CKD, I might use it for a short period of time, but I would not use it for an extended period of time because of the buildup of active renally excreted metabolites. For those of you who are interested, morphine's metabolized in the liver to morphine 3-glucuronide, morphine 6-glucuronide, and morphine 6-glucuronide crosses the blood-brain barrier, gets into the brain, can cause altered mental status and somnolence. And so that's the reason why we tend to avoid it. And not only that, morphine 6-glucuronide comes out of the brain very slowly, so it can be a real problem. So this is from Sarah Davison's article in CJASN in 2019, treating pain. As long as the patient's on dialysis, we said that hydromorphone could be used. If you're stopping dialysis, I wouldn't recommend hydromorphone. If you're treating outpatient, oxycodone might be the one that I might start with, or depending upon your comfort with buprenorphine, fentanyl, or methadone, those are possibilities too. For neuropathic pain, She and her group suggest starting with gabapentin. Notice the low doses. If that doesn't work, going to carbamazepine. The brand name for that is Tegretol. And then tricyclic antidepressants, they talk about amitriptyline. Amitriptyline is fine as long as the patient could use some help with falling asleep, staying asleep, because amitriptyline is more sedating than the nortriptyline or desipramine that I mentioned on a previous slide. And notice here are starting doses, and then you would titrate up till you've relieved the pain. Now, acetaminophen, you want to adjust the dose because of liver and kidney disease. And notice she recommends a maximum of 3 grams a day. And it can be used really as adjuvant therapy in addition to opioids or the anticonvulsants for neuropathic pain, and can help can help reduce the pain a little bit further. You can also use. She also talks about using even a topical NSAID such as diclofenac gel for bone and joint pain that might be helpful. And we have the references for all these things that you can, if you're interested, look them up and expand your knowledge even further. Now, this is for evaluating anxiety and depression. Studies show that dialysis patients anywhere between 25 and 40% report anxiety, anywhere between 25 and 40% report depression. And you might be keyed in to the anxiety or depression because of the patient's responses on the Edmonton Symptom Assessment Scale or the IPOS Renal, or even just in conversation with them, they might tell you they've been worrying a lot or anxious or they're depressed. And so if you suspect that they have a psychosocial need, then the next thing is to do some sort of formal screening. And I'm not suggesting that you do the Patient Health Questionnaire 9 or the Generalized Anxiety Disorder 7-item scale, but what I might suggest you use is the Patient Health Questionnaire 4, because it's limited to 4 questions. So I'm going to advance the slide and then I'll come back. So here is the PHQ-4. And notice the way you would administer this, or your social worker could administer it, or your nurse could administer it to patients that you suspect of being anxious or depressed. And remember, treatment of anxiety and depression were rated highly. It was important to patients when they gave their priorities to improve their quality of life. So the way you would ask this is, over the last 2 weeks, how often have you been bothered by feeling nervous, anxious, or on edge, or not being able to stop or control worrying? So the first 2 of these are the anxiety questions, and patients can say not at all, several days, more than half the days, nearly every day. And you would take these 2 and sum the responses for these 2, and the instructions for this screening scale say that if it adds to 3 or more, you should refer the patient for evaluation to a psychologist or to a social worker, to somebody who could treat their anxiety. Now, the depression questions are the second set of 2. Over the last 2 weeks, how often have you been bothered by feeling down, depressed, or hopeless? Again, 0 to 3 scale, or having little interest or pleasure in doing things, which is called anhedonia. And again, you sum these last 2, and if it's 3 or greater, you might want to refer your patient for treatment for depression. Now, so where are we? So coming back, you've done your screening. Maybe they score positive on the PHQ-4. And then you would do a more comprehensive evaluation, and then you might even refer them if they score, and here are scores on the PHQ-9 or the General Anxiety Disorder 7. If they scored 10 or higher, then you might want to refer them for treatment. And the 2 options are things like SSRIs for depression and anxiety, or cognitive behavioral therapy. And of course, we know SSRIs can take 4 to 6 weeks to take effect. So cognitive behavioral therapy, patients report an improvement in their symptoms really after just a week. So that if it's available to you, I might encourage you to use cognitive behavioral therapy for anxiety and depression in your patients, with perhaps medication as the backup or as an adjunct. And so this is where, if you have supportive counseling, pastoral counseling, self-help groups that patients can attend, those can be very helpful. And I think one of the sad things is these things are not more generally available to dialysis patients. And I think we all have experienced the fact that since dialysis patients have to make a trip outside the home if they're in-center hemo 3 times a week, they really aren't eager to go a 4th time a week to see a psychologist or some form of counselor. We showed you the PHQ-9 questions, which have been validated in dialysis patients. And then this is from a good study that Paul Kimmel and group had in the American Journal of Kidney Disease in 2019. And some of their findings: anxiety symptoms are independently associated with increased risk for hospitalization and death in hemodialysis patients. Certainly that's a good reason to address anxiety symptoms. In hemodialysis populations, mental health is as important as comorbidity and symptoms in determining quality of life. That's a second really good reason to look at anxiety and depression. Social workers should be deployed as they are trained to attend to the psychological status of the patients, not merely to transportation and insurance needs. And I certainly agree with that. And as I've talked to social workers, they say that they would love to have the time to really help talk to their patients about their anxiety and depression and counsel them. Cognitive behavioral therapy is safer and more effective than benzodiazepines. And just for those of you who have not been following the literature on benzodiazepines, they're associated with an increased risk of motor vehicle accidents, falls, hip fractures, and possibly dementia, and certainly even greater risk as the patient gets older. So there's a real move away from using benzos, even though in the short run they seem to be very effective to treat anxiety, and to use these other modalities of treatment. And then I think we would all agree mental health therapists need to be more widely available to treat patients with kidney disease. Now, if we talk about depression, there are pharmacologic interventions, and notice that citalopram, escitalopram, fluoxetine, which I had to look that up, that's Prozac, and sertraline, that's Zoloft. These have been tested in clinical trials and found to be effective. Here's a Cochrane database systematic review from 2016. And then I'm going to mention this book later on, but there is a new book just came out last year from Oxford University Press, Palliative Care in Nephrology, and there's really an excellent chapter on systematic psychosocial and spiritual needs assessment and management in patients with chronic kidney disease and on dialysis. And so that would be another really good resource for you to read more about use of pharmacologic interventions and cognitive behavioral therapy that can include psychoeducation, behavioral activation, cognitive restructuring. So cognitive restructuring is helping patients reframe their negative beliefs into more adaptive or positive beliefs, healthy living. This would be a way to actually address noncompliance, help them with sleep, help them with somatic symptoms, existential concerns. And they use things like motivational interviewing to try and really increase the patient's desire to change their behavior. So if you have some patients who are non-compliant with diet, fluid regimen, the new word is non-adherent, you might consider cognitive behavioral therapy as one way to treat that, in addition to treating depression. Now, we'll move on to another troubling symptom. And remember, this was consistently in the top 3. And then again, this was reviewed also in another chapter in this new book, Palliative Care in Nephrology. And let's first of all acknowledge that management of uremic pruritus can be challenging. There is a stepwise approach, non-pharmacologic and then pharmacologic, to treating it. There are all sorts of good algorithms. And if non-uremic causes are not present, so if there aren't other reasons like liver disease to be causing itching, then uremic pruritus treatment should focus on general strategies first. Make sure the patient's not under dialyzed, make sure the calcium phosphorus levels are in target range, make sure their skin's not dry, make sure they're eating adequately, make sure they're not iron deficient. So addressing those things. And then the first line then is really to practice good skincare with moisturizers with glycerol or high water containing emollients. You can Google them, look them up. I talked about oil-based soaps like Dove or Camay that also can be very helpful to do a better job of lubricating the skin. Now, in addition, if those things aren't working, there are 2 creams or ointments that could be applied. to relieve the uremic pruritus. Some patients don't tolerate the capsaicin because it causes burning even after they persist at it with a little while. And then the oral therapies that are evidence-based, again, gabapentin, it seems like gabapentin is appropriate for a lot of things with dialysis patients. Unfortunately, a lot of dialysis patients don't tolerate gabapentin. But again, you should start low, go slow, titrate up. And you could use gabapentin, or if their insurance will pay for pregabalin, you might start with pregabalin. Ultraviolet B phototherapy has been found to be helpful with some dialysis patients. Acupuncture is found to be helpful. And what you really want is a clear plan of management, regular close follow-up. You want to encourage patients. I'm going to work with you on this. We're going to try and figure out how to help you do better with this. And again, remember, even cognitive behavioral therapy has been found to be helpful to help patients manage their anxiety and their attitude and how they respond to physical symptoms. Now, you might say, all this sounds really good. How are we going to do this in our dialysis center? There are all these challenges. So let's look at them. On the left side are the challenges. On the right side are the strategies to overcome the challenges. And notice that something called the Pathways Project, the Pathways Project, and we'll have a reference for that on the slides at the end. The Pathways Project, evidence-based best practice recommendations to improve supportive care delivery for patients with kidney disease, this is number 10, best practice number 10, and there are 14 best practices with a review of the literature and recommendations like this one. So you need a system to routinely screen patients. So we talked about the ESAS renal or the IPOS renal once a month in the dialysis center or on each CKD clinic visit, and then you would record the answer in a designated location, ideally in the electronic medical record. Maybe you could get your IT people to set one up for you so that then you could populate it, figure out how to populate it, and maybe even have an iPad for the patient where they do it, and then it populates into the record, and you can then track the response over time. And the second challenge is many clinicians do not know how to treat pain or symptoms. And so the recommendation is to identify a champion, whether it's a physician, nephrologist, whether it's a consultant palliative care physician or nurse practitioner, whether it's a nephrology nurse practitioner or nephrology physician assistant, even a nurse in your dialysis center who wants to spend a little extra time learning about these, how to assess, how to treat, and be sort of your go-to person for patients with really troublesome symptoms. And another concern is an appreciable number of CKD and ESRD patients will have substance use disorder, and you really don't want to use opioids. And so somebody, maybe your champion, is going to get some training on safe prescribing of opioids, or opioids might be something that you want to let your specialist, your palliative medicine specialist handle for you. But you might need at least a mechanism for how do we refer patients with really severe pain so that they can get their pain treated to improve their quality of life. And then if you just don't have any time because you really have lots of other commitments and priorities, this is where the staff member who's going to get some training, maybe attend some palliative medicine courses, maybe listen to some more webinars like the one we're doing. There's one last week on active medical management without dialysis. The one the week before that the RPA sponsored was on communication skills to have goals of care conversations, to let that staff member get that type of training so that they will be better at doing kidney supportive care for your dialysis patients. So I promised you that I would give you resources. So the British Columbia Renal Symptom Assessment and Management guidelines are very helpful. And here's the website where you can go to get them. And then also in Alberta, the Canadians have been really good at this. And of course, the Australians have been too. But there's a CKM, or Conservative Kidney Management Symptom Management Guidelines, that you can find at this website. If you want to download and print off the ESAS renal to use with your dialysis patients, here's the website for that. If you want to use the IPOS renal, here's the website for that. If you want to use the PHQ-4, Patient Health Questionnaire 4, to screen for anxiety and depression, here's the website for that. And then if you want the New South Wales Renal Supportive Care Program approach to pain and symptom management, here is the website for that. So you don't have to believe that these symptoms are untreatable. There is a lot of help available to you for free on the internet. Now, I've mentioned it a couple of times, so I need to disclose I am an editor, one of the co-editors of this Oxford University Press book, Palliative Care and Nephrology. And here is the URL link. If you type in this link, and then when you get to search, it will, and then just type in nephrology, and it will bring up this book. And really, we invited authors who are experts in their areas, both national and international, and to our pleasant surprise, not a single person that we invited turned us down. So really, we do feel like this is an excellent resource for you. If you want to learn more about active medical management without dialysis, here is a website where you can go for that. And notice that we've presented, so in Kidney 360 is a description of the intervention in the Pathways Project. And then this is actually a poster. Really, we had a similar poster at the American Society of Nephrology and the American Academy of Hospice and Palliative Medicine. And really, so the approach that we talked about in the first RPA webinar did work to systematically identify seriously ill patients and then have goals of care conversations with them. So in conclusion, let's just look at this now. Symptom assessment and management are important to patients with kidney disease, and by paying attention to these things, you can improve their quality of life, and improving their quality of life is what is most important to them. It's dialysis patients, 3/4 of them consistently report quality of life is more important than quantity of life, and dialysis patients are willing to make trade-offs, even in terms of 6 to 12 months of life, so that they will be living with a higher quality of life and actually be more independent, is what they report. And at present, neither assessment or management of these symptoms is done well. And to improve the care of patients, you really need to systematically attend to their symptoms. So I'm hoping that I've encouraged you to download the ESAS Renal and IPOS Renal and take a look at them, maybe try them out on your patients, see which one is going to work better for you, see how you can work it in to your overall management of your dialysis patients and your CKD patients, and then make sure you assign clear responsibility to somebody in your dialysis center or somebody in your office practice about who is going to be asking and using these symptom assessment tools. And then with using these validated tools and the algorithms from British Columbia, Alberta, New South Wales, Australia, then you'll be able to know how to manage patient symptoms better. And then really, for those of you who are interested, at last count, I think I counted 50 nephrologists who are dual board certified in palliative medicine as well. If you're really interested, you can do these things that I mentioned and just pick up some additional primary palliative care knowledge and skills, or a few of you listening, perhaps some fellows might think about doing a palliative medicine fellowship as well as a nephrology fellowship, because there's a huge need to improve symptom management for our patients to improve their quality of life, as we've talked about. So with that, I would like to conclude. I'll turn this back to Desiree for whatever questions there might be in the chat or in the questions and answers. And I thank you for your attention.
So the first question, Dr. Moss, is, would it be fair to say you would agree with Dr. Kimmel regarding social workers being deployed?
Yes, I would. I think they can be very valuable resources. In research that I've done, I've worked with social workers, and they've been very, very helpful to help patients.
Okay. Now, this was a question from Susan. One, how to get a copy of your palliative care book, and then your comments on palliative care in CKD clinic.
Okay, so the book is available online. Just Google it. It's published by Oxford University Press. So it's easy to find. And then really what Steve Weisbart has done has shown that patients with advanced chronic kidney disease not being treated with dialysis have the same symptoms to about the same severity, interestingly enough, as patients on dialysis. So the very same things we were talking about today is effective for dialysis patients also would be effective for patients with advanced kidney disease.
Okay. And that, I don't see any more questions in the Q&A. If anyone has another question, if you want to quickly type it in there, and we could certainly answer that for you. I'll also see if I can provide a link to your book as well and send that out. But I did send out with the login information, the presentation each time. So we'll also make sure that everyone has it. If you didn't get that email or have that copy, please shoot me an email. I'll be happy to forward that to you. What is your experience with mirtazapine? I'm not sure if I'm pronouncing that correctly.
Mirtazapine, right. So mirtazapine is a good drug for nausea to help patients sleep at night as an antidepressant. So often to help patients sleep, you might start with just 7.5 milligrams at bedtime. Even to treat depression or nausea, I would start low in dialysis patients. I'm not aware that you have to adjust the dose for their level of kidney function, but that also can be a helpful drug. I don't want to tell you it's going to work in every patient, but maybe 30 or 40% of the time, you may get a good response.
Okay, thank you. If that's all the questions that we have, again, we want to thank everyone for participating. This has been a great series. We'd like to thank Dr. Moss for putting this together for us and being our presenter for all three. Dr. Dale Loop, who presented in the first two, so we appreciate her as well. The recordings are on the RPA website as well as in the RPA e-learning portal. The third one, we'll re-record that and get that up online, and I'll let you know when that is available. Again, if you didn't get the email with the presentation, please feel free to email me and I'll make sure that you get that. I'll even see if we can put it on the website. It'll definitely be in the e-learning portal. I don't know if we can put it on the website, but thank you all for participating. We hope that you have a great afternoon and enjoy the rest of your day.